Hi everyone, welcome to this BSR webinar. It's great to have so many of you here. Just a few housekeeping things for me to start with. Please keep yourself muted if you can, because there's an awful lot of us on the call today. But by all means, switch on your camera and put up your hand if you want to ask a question or put yourself in the chat. The plan is to keep it quite informal, but I am going to talk through some slides to set the scene, and then we'll have a Q&A session, and please feel free to ask us your questions. It's hopefully going to be a bit more interactive. We're talking about some things that we're not 100% certain ourselves about yet, so hopefully be quite interesting as the time goes by. So just to introduce myself, I'm Liz Price. I'm a consultant rheumatologist at the Great Western Hospital in Swindon. Like many of you on the call, I'm a jobbing rheumatologist. It's a DGH. We see patients and put them ourselves into the NEIAA audit. So next slide, please, Sarah. I should introduce Sarah Gallagher, who's in the background. She's the pivotal person at BSR for the audit, and you might see or hear from her later. So just to warn you that we are recording the whole webinar, and it will be available later on the NEI website. And if you want to go back to any of the previous webinars or recordings, you can find those in the same place or by scanning the QR code. Thank you. Next slide, please. So I'm going to start by giving you a little bit of an overview. So the National Early Inflammatory Arthritis Audit, or NEIAA, which you all know and love, was actually commissioned 5 years ago by the Health Quality Improvement Partnership, known as HQIP. And that's along with lots of other national audits that run across England and Wales and look at things like hip fractures, etc. But this one was specifically looking at the quality of early inflammatory arthritis care. And the idea is that it benchmarks us against the quality standards. Now, you won't be surprised to hear that rheumatologists were very closely involved in those NICE quality standards. And you can Google them if you're interested, the NICE QS 33 quality standards, which refer specifically to newly diagnosed rheumatoid arthritis. And up until April this year, the audit was collecting anybody presenting through a rheumatology department with probable or possible early inflammatory arthritis. And what most of us found in most departments is that for every 3 patients we saw, maybe 1 would turn out to have early inflammatory arthritis and the other 2 was something else. So we were putting in quite a lot of data, some of it on patients who weren't then carried forward into the audit. So to focus it, we've now decided from April this year that we're only asking you to enter data on patients who have a confirmed diagnosis of early inflammatory arthritis. And we've extended the audit a little bit to include other conditions, and we've reduced the amount of data inputting you have to do. We got rid of questions that weren't discriminatory, weren't adding anything, or questions where we ourselves could get the data through other means, such as the NHS spine. So as well as early inflammatory arthritis, we're now asking you to put in data on connective tissue diseases and vasculitis. And the only major condition that you might see that is an exception to that is polymyalgia rheumatica. And it was decided in the end not to include PMR in the data collection because the bulk of patients are actually seen in general practice and only the difficult or chronic ones are seen on the whole in secondary care. So next slide, please. So what are the key measures that the audit is measuring? These are the things that the QS 33 sets out as being important for patients with early rheumatoid arthritis. They want prompt GP referral, and the target is actually, amazingly, for the GP to refer within 3 days of seeing the patient. They want us to see the patient with probable early inflammatory arthritis in a clinic, in a rheumatology clinic, within 3 weeks. They want us to start treatment within 6 weeks. And they want the patient to receive appropriate education, access to a helpline, and a holistic annual review. Next slide, please. So what has changed? So as I said at the beginning, we're not just including early inflammatory arthritis. We've expanded the data set to include patients with a diagnosis of connective tissue disease or vasculitis. At the moment, those diagnoses are there for you to enter the data if you want to. It isn't becoming mandated until September. So you've got time to start playing with it, putting the data in, and we can see how it pans out and how people get on with it and make changes if needed. Overall, the amount of data you're putting has reduced dramatically, not only in the number of questions you're being asked to answer at baseline, but we're only collecting a 3-month follow-up data set on the RAs only. We're not collecting 12-month data on anyone, and we've dropped the requirement of 3-month data sets on anybody other than the RAs. What we are going to emphasise a few slides down is the importance of the patient-reported outcome measures, because we're collecting that on everyone. Next slide, please. So these are the patients we're looking for. So early inflammatory arthritis, the bread and butter of rheumatology clinics, rheumatoid being the biggest one in that group, but also data on psoriatics, axSpA, and that slightly tricky group with undifferentiated early inflammatory arthritis. In the connective tissue diseases, again, fairly standard stuff, the lupuses, Sjögren's, systemic sclerosis, the inflammatory myopathies, and that, again, slightly tricky group of undifferentiated CTDs. In the vasculitis group, the only important one that's not there is PMR. So we're looking for GCA, large, small, medium vessel vasculitis, the anchors and the non-anchor associated, and the Behçet's. And as I said, those last two groups, the ones in blue, are not mandated at the moment, but they are there for you to enter, and I would strongly encourage you to give it a go. Next slide, please. And why are we doing it? Well, this is, at the end of the day, about quality improvement. We are not doing this to tick a box. We are doing this to improve outcomes for patients. And if you're going to improve patient outcomes, you need to get involved. If you want your patients to get a better service, you need to be invested in this and actually take ownership, I think. So we want you to put the data in, we want you to put it in honestly, and then use it to inform change, to look at, oh, someone's come on. If you could turn off, if you could mute, please. To inform change, to make sure that you're delivering the best possible service with the resources you've got available. The other thing for adding the additional patients was that it is been a kind of slightly perverse incentive for us to prioritise patients with rheumatoid over and above patients with other conditions, which might be just as important. So in order to change that, we wanted to add the other conditions. And the other thing, which I'm quite passionate about, is the lack of data, lack of diagnostic coding data in rheumatology, which really impacts on our ability to plan services. So like most trusts, my trust collects new patient and follow-up data, and that's it. I don't know what those patients had, what their diagnosis was, and that makes it difficult to plan services for the future, to say, well, we need somebody to specialise in X, Y, or Z, we need more clinics for this. So that's one of the reasons to collect a broader database. Next slide, please. Lovely. Okay, so how are we collecting the data? Well, I'm sure most of you on the call will have done this already. Data is collected in the clinic using a clinical questionnaire, and also from patients themselves via the patient questionnaires. Now, both data sets are really important, but can I really emphasize on the call today the importance of the patient-reported outcome measure data set? Now, I was quite taken aback when I got involved in the audit to discover that to date, only about 12% of patients fill in their data. And I think probably that's partly, at least, due to us. And I think I've become more aware, since I appreciated that very low figure, of the importance of discussing this with patients. We do have something called a CAG arrangement, which means that we don't have to get actual informed consent to put a patient's data into the audit. But I still think it's common courtesy to let the patient you're putting their data in, and to ask them about them putting in PROMs data, and to also, I hope, encourage them of the importance of doing it. We're collecting a very rich patient data set, and that's really going to inform future developments. Next slide, please. So talking a bit more about PROMs. So why do we do it? So it's to collect data on the impact of the condition on the patient. Yeah, so it's not just what we think, it's what the patient thinks. That's really important. Collecting that data will allow us to do some quality improvements. So if patients say they're not getting enough education, they don't understand enough about their disease, then we can change the way we deliver services. And it does make sure that the patients are being looked after in a safe environment. They feel safe, they feel well looked after. It's a patient-centered environment. So next page, please. So who should put in the patient data? Well, all patients ideally should put in the patient data. And that doesn't matter what their underlying diagnosis is. So please encourage your patients to do it. And interestingly, I've been involved recently with some of the patient charities, and they're very keen for their patients to have the access to putting this data in, because they feel it's only by putting data in and informing us of the impact of the conditions on the patients that things will actually change. So once you've put a patient into the audit, they are invited to complete the patient questionnaires at the baseline, and then again at 3 monthly intervals right the way up until 12 months. So although we're stopping longer data collection from the clinicians to take the burden of collection off you, we're actually asking the patients to do a little bit more. Next slide, please. So what are we collecting? So they're being asked about gender, ethnicity, smoking status, symptom duration, and we're using standardized questionnaires, the MSK Health Quality Questionnaire, the Patient Health Questionnaire, a generalized anxiety disorder scale. We're looking at work productivity. That's really important. And one of the things that the Department of Health is particularly focused on at the moment is economic activity and the importance of keeping people economically active. And as a consequence, MSK has gone up the agenda nationally because they perceive that one of the big reasons for people not being economically active is MSK conditions, not just the ones that we see, but the ones that the GPs see, the more broader, back pain ones and so forth. We're asking for patient global assessments, provision of education, and that's a really interesting one because although most of us do tick the box to say that we do provide education to our patients, a much lower proportion of patients tick the box to say they've received education. And that might be to do with perception. So I always talk patients through, I give them leaflets in clinic, and I think that counts as education, but the patient may think that they only get educated if they go to a class or a lesson or a group meeting, etc. And we can explore that once we know that data. We also asked them about whether they were given a treatment target. So were they told that the aim ideally is to get their disease into remission? We asked them about the use of allied health professionals, the broader MDT. How involved were they with the broader MDT? How involved were they with their decision making in terms of the condition? Were they allowed to make a decision themselves? Were they given enough information to do so? We asked them about cardiovascular risk assessment and bone health discussions. Next slide, please. So how are they collected? So many of you will have already done this and will know this, but when you enter a person into the database, there is a question at the bottom that asks you to enter their email address. Now, we have got rid of the box that asks for a telephone number because what I realise is that there is no fairy out there ringing the patients up and inputting their data. If you don't put an email address in, the BSR cannot send them the automated forms. So if you don't put an email in, then their data, they won't get a chance, an opportunity to enter data. Now, I appreciate there are a few patients who don't do emails and are nervous about emails. There is still the ability to download the forms and fill them in, but then the onus, I'm afraid, is on you to get that information uploaded. So far, far better to get an email address out of them. What I would say, and is that it is important. I personally, I would delete an email from someone I didn't recognize. So it might be worth warning your patients about the email so they know it's coming, so they don't just ignore it. And when they get the email, it will invite them to link into the web-based platform and enter their data directly. So please just raise awareness with your patients on that. The patient charities are pretty good at this as well, and we're going to ask them to do some raising awareness as well. Next slide, please. So this is a real hot potato at the moment, the national data opt-out, and I suspect it's why so many people have signed in today. So you will have all got an email on the 7th of July saying that we no longer have the national data opt-out. Now, we're not alone in this, and this is happening to many of the national audits. So this is coming across the board, and it's something your trust should probably be aware of, and which I've highlighted to our trust. So what is the national data opt-out? Now, many of you, I'm sure, will have forgotten, but some years ago, you will have been asked directly, either by email or letter, did you want to opt out of national data collection? I had completely forgotten about it. I don't think I did opt out, but I do know several people who did opt out. And if you opted out, that data is recorded on what they call the NHS spine, which is a national collection of data identified by NHS number, not by hospital number, by NHS number. Now, trusts have access to the data it should be through your audit department, your information governance department. And what they can do is they can interrogate the database as long as they have the NHS number to work out is the patient involved someone who's opted out? And unfortunately, if the patient has opted out, then you cannot put them into this NEIA audit. Now, that is a shame, because actually I do know, we've had this conversation with a few patients who've opted out of national data collection who would like to be in the audit. But I'm afraid the way that the world works, if they've opted out, we have to take them out of the audit. So the onus now is on you and your trust to identify those patients. And now I'm very aware that that is not necessarily easy and straightforward. So you will need to have a think about how you do it locally. So we're thinking about it, how we do it locally. And we've been having lots of conversations this week about it. And I can reassure you that it is probably not as complicated as you fear it might be. So the conversation I had with my audit department on Wednesday went along the lines of, well, all right, then if you give us the NHS numbers, we can do it for you. I had my report back today. So somebody in audit, we sent, or they collected the NHS numbers. In fact, the way we did it was we sent them a list of NHS numbers. They've gone into the spine and they've reported back that one of the patients we've entered actually needs to be taken out or can't go in because they're a national data opt-out. I asked my audit guy, how long did it take you? And he admitted that once I'd sent the numbers to him, it took him 15 minutes. So it is not a difficult exercise once they've got the numbers, but it's the NHS numbers that are key to that. Lovely. Next slide, please. And this explains everyone must comply. So all NHS organisations, whether you see these patients privately, NHS, wherever in the NHS you see them, it covers everything. And that's why even if the patient says, oh, actually, I don't think I do want them to opt out, we have to take their data out. So just please liaise with your trusts about that. Next slide, please. Right, Q&A. Now I can see there's a question there already. What I can't see, unfortunately, is whose hand it is, but maybe Vesna Hogan. Do you want to unmute and ask your question? Hi, Vesna.
I'm a clinical audit facilitator here for East Surrey Hospital, and
hello.
I work for medicine.
Hi.
Yeah. Just to answer your question about opting out. Basically, I have spoken to NEIAA and also to some other national audits. The patient can be entered into the database as long as they consented and you have a written consent from them that they want to be a part of the audit. Yeah, there are patients that opted out on the spine, but they still want to be part of the audit. And as long as you obtain the informed consent form from them, signed by them, and it's filed somewhere in the notes or electronic notes, then the patient can be part of the national database.
Oh, that's really interesting information. We need to take that away and have a little think about it, because we did talk about this. That's in slight conflict with our CAG status. So the CAG status means we don't have to ask for consent. So this is kind of in direct conflict with that. I kind of get, and I must say, I feel that sounds right. The question will be how you set up that consent process and how you evidence that consent process. But that's definitely something that we're discussing at the moment. I'd be really interested if you've got a workaround and what sort of paperwork and so forth you're using. We have talked about whether we have, buttons on the database, drop-down boxes and so forth. But this is something that we are actively discussing this, and I'm sure this is something we'll come back to you about over maybe by the next webinar, I hope, with a little bit more concrete information, because this is still a work in progress. But that's really helpful. Thank you very much.
Yeah, because it's actually another national audits. They have some helpful kind of stuff on their websites about this.
Perfect.
And,
yeah.
So yeah, and fact, also regarding the we have through informatics, we've got a link which we can send our NHS numbers through to be checked on spine. And it doesn't take that long. It takes only a couple of minutes.
Yes.
And it's really straightforward, really.
Yeah, now that's the feedback I've got. It's very quick to do, but it's actually just the doing of it. And it's making sure you do it before you put the patients on the database. That's really helpful. Thank you so much. Lorraine Croot from Barnsley, is that right?
That's right, thank you. So I've just got a question about the PROMs platform and the BSR PROMs platform. So if you want to collect data for longer than the audit is going on, do you then have to register them in both platforms?
Well, that's a really good question. I suspect the answer will be yes. I know I've got Sarah and Callum on the call. Do either of them know the answer to that question? If we don't, we can always answer it afterwards. But yeah,
that's fine. So
Nina's put her hand up. She's the perfect person to answer. Nina, tell us the answer.
Sorry, Sarah, you might have had the answer there. The two systems are actually not linked. They're totally distinct systems, and we will be sending out some information about the EPROM system going forward, because we're changing the use of that. So I think the standout message will be that the only way to collect PROMs from patients will be through NEIAA, and that will be for a maximum of 12 months. I'm not sure there's going to be any facility going forwards to collect for a longer period.
Okay, that's interesting. I've got a question on the chat here. Spine is being replaced by a new system in September called NCRS, which so far is not permitting us to see if patients have opted out. Does anyone know another way to check if patients have opted out? Well, it's interesting. So I've asked our trust, can they flag the patient's electronic records? Because we already have flags for allergies, overseas visitors, all sorts of things like that. So I've asked them to, and if the patient's in a trial, and they are actively looking at whether they could actually flag the patient records. So you get, when you log in, you get a little flag that says alert, and you can check it out. GP systems seem to be able to do this automatically, so I'm not quite sure why hospital systems can't, but we can certainly investigate that and see if there's any workaround for the NCRS. I've got a few more questions coming through, okay, so someone else from clinical audit feels that a patient can overrule their own general opt-out for a specific project, but you'd want to get that adequately documented. So maybe that's something we need to take away after this meeting and have a good think about.
I have also just captured some questions from earlier on. So the first question we had from Dave Saunders, I believe it was. So regarding the national data opt-out that we no longer have in place for NEIAA, are there any plans to add questions regarding this to the data set so we can both be assured of our compliance in this regard? Also, is NEIAA going to reapply for an exemption as some other national audits have in place, for example, SNAP, who have a long-term agreement in place till 2026?
So yes, this is under discussion, and we have talked exactly about this, about having the, your first line when you log into the database to enter a patient being, has the patient consented, or are they part of the, and drop down box. We're not sure about that yet, because as I say, we have implied consent, just we don't have to ask for consent, if you see. So that's kind of counterproductive, but we will think about that, I think. And the second one was, remind me what the second was, Sarah. My mind's gone blank.
Okay. Are we going to reapply for an exemption?
I think we have, haven't we? We've tried.
Well, what we're going to be doing is we're going to be speaking to other audits in the NCPOP program. I have a call with another one next week. And I think we have enough feedback from services now of the impact of this that we can go back and restate our case. And continue the discussion with CAG to see whether we can have that exemption.
Yeah, so we're actively working on that. And we'll update. There'll be lots of updates coming through over the next few weeks, I imagine, and months, because this is a bit of a work in progress. So we've got a lot of things happening at once. We've got the increase in the patient data collection. We've got the new diagnoses, and we've got the NDO, the national data opt-out, all happening simultaneously. So there's an awful lot going on in this space at the moment. Any other questions?
Yes. So a question here, is there any facility to upload the EPROMs so that we can send out on patient portal?
I'm not sure I know the answer to that. That's a bit of a techie one, isn't it? Does anybody?
Yes.
Callum? Sorry, not that
I'm not sure of the answer to that one.
I think Nina's already said they're two very separate programs.
They are
platforms, and they're not currently linked. Now that is something, because of course EPROMs was set up as a separate project, wasn't it? What I don't know is how compatible they are and whether it's possible. We can look into it. We'll certainly look into it and let you know. It'd be lovely if we could, wouldn't it? You don't want to do things twice. That's the problem. I get that. Absolutely get that.
And just a final comment from Zoe Ash. Any extra steps like checking data opt-out are likely to impact on your recruitment? So not a question, but a statement. And I would just urge anybody who is seeing that impact in their services on recruitment to the audit to feed that into us. We've had some really good feedback on the impact of applying this opt-out, and it only helps our case with trying to argue for a further exemption. So we would just urge you to feed that back into us.
Yeah, and I think it partly depends on how you do this audit. So I know different departments have adopted very different models. So personally here, we put all the data in ourselves. But I know that some and some units have the audit department doing it entirely, and then there's lots of in-betweens. So the question is, you know, how much you have to do. I think we're working on a workaround for us, and I think we'll get there. But your workaround may depend on the way you structure your data entry. What I would say is that on a personal level, I do not find it particularly onerous putting this data in. If you know, particularly the first set of data, it calculates the DAS score for you, which you need to calculate on every patient you see anyway. So in that respect, and since the change, if you were someone who was entering data before and you're now entering it now, I think you will see the difference. Any other comments? Oh yes, I've been reminded, because I've already forgotten, to ask you to give feedback. And there's a little click. You can either do one of those fancy QR code things, or there's a hyperlink in the chat, please. Any further questions?
There's no more questions. Oh, sorry.
Okay. So if you don't want to say them, you can put them in the chat, and you can also send them afterwards. Actually, that's a fair point, isn't it?
Yeah.
Sorry,
yeah.
I didn't put the hand up, but
yes,
I always have this thought about that question, that it's related to unpaid work or something like that. I can't remember exactly the wording of it. It's on the first page when you're entering the data, and it's asked how many hours of unpaid work it's been done and things like that. And obviously, if you don't have that information, and that is kind of stopping everything to be locked and things like that.
Yes.
And I don't know how to overcome that. And I mean, the clinical teams, they're constantly asking me what to do with this.
Well, I think it depends on how you run the audit. So we put people in at first consultation, and I'm a bit OCD, but I was taught as a junior doctor, as a medical student, that one of the first things you ask the patient is what's their occupation and are they working or retired? And that is a really important question. So actually, that should be captured by the doctor at the first consultation. The other issue, of course, is that it is captured, I think, in the PROMs data. So, and you can see your patient's PROMs, is my understanding. Is that right, Sarah? So you could look into the patient's PROMs.
Yes, you can. Yeah. Services have access to the PROMs data, and we encourage use of that data.
Yeah. So you could look at the PROMs data. It's the top buttons along the top. Yeah.
Yeah. Okay. And so, I'll let them know that.
Yeah,
because we've got the nurses entering this data, and it's not prospective data collection, it's a little bit retrospective. So and we just kind of restarted the data collection because we had a bit of a problem with staffing, so no one was entering the data for some period of time. But yeah, it's that's something that it's kind of always, oh, what do we do now? We can't lock the record and things like that.
And we are trying to encourage the people who, you know, the people on the whole, for first patient consultations, they're usually the medics doing those rather than the nurses. It depends on your model exactly, but in most situations, the medic would see them on the first visit and then the nurse does the follow-ups. So a lot of the onus is on the medic at the first time to do that data entry. I think we're trying to incentivize, particularly junior doctors, by issuing certificates. Is that not right, Sarah? That you've been entering data. So, because it is something you can put in your portfolio.
Yeah, we tried that before, and it's
have you?
Not,
okay.
Unfortunately.
Well, if anyone's got any good ideas about how to encourage doctors to do it, other than having someone like me wagging their finger at them, please let us know, because that would be helpful. And there's a question in the chat, or a mention in the chat, about the paper version not including drugs.
And this might be one we'll need to take offline, just have a look into it. So about drug education, so can't progress after this question.
Lovely.
Okay, that's fine. And we've had really good engagement with this webinar. So just whilst I've got the floor, I'd just like to thank everybody for joining us. And please do feedback via the survey because it just helps us with setting out webinars that are useful to you and your teams and to the community, and just increase that engagement with the audit and educate you on how you can use the audit to fuel quality improvement within your services. So yeah, thank you for taking the time to join us, and we'll distribute any of the questions and answers afterwards along with the recording of the webinar.
That's lovely. And a big thank you from me as well to Sarah, the team at BSR, and all of you for listening. So thank you very much.